Thank you all for joining us for today's webinar, Comparative Contraception Webinar Series, Long-Acting Reversible Contraception. My name is Jessica Monmany, and I am the Senior Education Associate at ARHP. I will be moderating today's webinar. Before we begin, I would like to share how you can receive continuing education credits for this webinar. In order to receive credits, you must take the pre- and post-test. If you have not yet taken the pre-test, please click the link provided to you in the reminder email. About an hour after the conclusion of the webinar, you will receive an email from Caitlin Borswith, ARHP's Communication and Education Associate, with a link to the post-test survey. Your continuing education certificate will be generated upon completion of the survey. In 4 weeks, you will receive another email with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you have incorporated what you have learned during this webinar into your work. Completing the pre- and post-test, as well as this follow-up evaluation, helps ARHP ensure that we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce Dr. Wendy Grube, today's presenter. Dr. Grube currently serves as the Director of the Women's Health Nurse Practitioner Program and also as the Director of the Center for Global Women's Health at the University of Pennsylvania. Dr. Grube's specific aims in teaching are to enhance the quality of education to meet the demands of current APN practice and expand their awareness of culture, healthcare disparities, and systems of healing they will encounter in these new roles. Dr. Wendy Grube has been a nurse practitioner for over 30 years with extensive experience in the field of women's health. She has worked to improve access to gynecological care for uninsured and underinsured women in a variety of community-based settings. Dr. Grube's current work is focused on increasing access to healthcare services for rural communities in the U.S. and in India. Dr. Grube's full bio is available on ARHP's webinar web pages. We're thrilled to have her with us today, and I will hand it over to her. Dr. Grube, you have the floor.
Thank you, Jessica. I would like to acknowledge the commercial support of Bayer Pharmaceuticals and Merck. It's because of their grant that we are able to present this information. I have nothing to disclose in terms of conflict of interest, and you can see here also other individuals that are responsible for putting together this evidence-based presentation. Something for you to consider as you're listening to this presentation is this is only one part of 3 presentations on comparative contraception. The second presentation coming up on September 14th is going to be done by Dr. Jamila Parrott, and it's going to be a discussion on permanent contraception. Some of the objectives that will be covered during that presentation have to do with the benefits, risks, and side effects of permanent contraceptive methods, identifying potential candidates for permanent contraception, and really discussing shared decision-making skills and informed consent strategies for fully understanding permanent contraception. The learning objectives for today's presentation really revolve around benefits, risks, side effects of long-acting reversible methods of contraception. Identifying who the potential are, and dispelling myths and identifying other potential barriers to the use of long-acting reversible method of contraception. So this slide shows us some of the data here from the most recent National Survey of Family Growth, and these are data from 2006, which was the latest available data. And what they show is we continue to have significant problems with unintended pregnancies. Almost half of pregnancies that occur in this country are identified as unintended. And if you look at the circle in the chart, you'll see that of those, 20% are just really bad timing. But 18% of them are completely unwanted, and this does contribute to an increased number of abortions. There's approximately 1.4 million of the unintended pregnancies end in abortion, and 1.6 million of these pregnancies resulted in live births. So the other interesting thing about this is almost half, 48% of these unintended pregnancies happen to women who have been using a method of birth control in the month in which they conceived. So what we have here is really a good indication that the problem, or a big extent of the problem, has to do with being able to use a method of birth control consistently and correctly. What we need here is more forgettable contraception. So this next slide really shows us what people are using. So about 62% of women between the ages of 15 and 44 who were polled said that they were using contraception. And of those, you can see that female sterilization and the pill are kind of equal at 17%. About 10% of the women claim that they're using condoms, and it doesn't necessarily identify whether they're male or female condoms. And then 18% include all other methods. And included in the all other methods, about 6% of those were male sterilization. So that was the highest number of the other methods. Intrauterine contraception was about 4%. Withdrawal was 3%. Injectable methods 2%, the patch 1%, vaginal ring 1%, and periodic abstinence or rhythm method was 1%. So you can see that the most effective methods of contraception were less used. So this chart is something that we should pull out in every patient visit. They really need a sense of perspective in terms of efficacy. And something like this, if you look at the top tier, the most effective methods, these are labeled most effective because less than one pregnancy per 100 women occurs in a year with the use of these methods. So we really talk about things like the implant and intrauterine contraception as reversible sterilization because the data show us that the efficacy is very similar. When you move down to the second tier, you have approximately 6 to 12 pregnancies per 100 women in a year that occur. And again, with oral contraceptives, there have been some studies in the past that indicate that missed and late pills are a common occurrence with women using oral contraceptives. When we get down to using things like male and female condoms, they're in the least effective category. They really, rely on very careful and consistent use. And withdrawal has a lot to do with the control of the male sexual partner. So this next slide gives us some idea of continuation rates. So if we're looking at trying to identify which women who are at the most risk of having unintended pregnancies, continuation rates are really important. So the LARC methods have the highest continuation rates. You can see between the copper IUD, the levonorgestrel containing intrauterine system, and the implants have the highest continuation rates. And at 3 years out, what we see is about the same continuation rates for both of the types of intrauterine contraceptives. And we have about 56% of the implant users who are continuing their method, as compared to the 31% of non-LARC users. And this is significant because actually after adjusting for age and race and education, socioeconomic status and parity, the hazard ratio for the risk of discontinuation was 3 times higher among non-LARC method users than among the LARC method users. So most women really are appropriate candidates. You know, in the past, we didn't really have this discussion about LARC methods with women unless they felt that they couldn't tolerate estrogens. And a lot of this was, you know, probably just the convenience and the familiarity of the provider. But now they're considered the preferable option for women who really need a highly effective, forgettable method of birth control. And again, you know, we still need to have this discussion in any women who medically cannot use estrogen. In terms of tolerance of irregular bleeding, this is a discussion that has to happen in the counseling, but irregular bleeding, remember, can happen with almost any method of contraception, not just the top-tier methods. And we certainly do have some ways of addressing irregular bleeding in our counseling and in our practice that can make these methods much more agreeable for women. So the first type of method that we're going to talk about here in detail is intrauterine contraception. Right now, these methods show the highest level of patient satisfaction among all of the methods. There's a very rapid return to fertility almost immediately after a device is removed. A patient can become pregnant. They are extremely safe and immediately effective. With the levonorgestrel systems, we do still suggest that a backup method of contraception is used for the first 7 days. But they do offer long-term protection, anywhere between 3 years to 10 or 12 years of protection. And again, highly effective, considered on the same level of efficacy as sterilization, and they are very low maintenance and not user dependent. So why are they so underused in the United States? Mostly because women really don't have all the facts. And there still is a persistent of myths about the IUD safety, especially among clinicians who have, and women, you know, who have some information from the previous intrauterine systems, such as the Dalcon Shield, that actually had some significant problems with them. The new methods are very safe and very effective. There's also been some negative publicity that if someone goes into a particular website, they may be attracted to a discussion board where people are talking about the, you know, some negative aspects, but a lot of them really can be misconceptions. And so, you know, our job really is to present the facts to women and clear up, identify and clear up misconceptions and myths. One of the other barriers is the upfront cost. In women who are uninsured or underinsured or don't have insurance coverage for contraception, this can create a significant barrier. And reimbursement concerns are probably, you know, more apparent to the providers. There's also not a lot of positive marketing out there. Probably the best marketing tool has been word of mouth. Many providers, myself and my colleagues, have really seen a lot of uptake now among friends of very happy intrauterine contraception users. So word of mouth has been probably the most effective at this point in terms of increasing interest in the use of intrauterine contraception. Also, there are issues related to fear of litigation among providers. So the results here were from a survey that were mailed out to over 800 practicing obstetrician gynecologists who were fellows of the American College of OBGYN. And again, there were some concerns that about litigation and again, myths of safety. So we're going to, we have a few polling questions in this slide deck, and this is our first one. So true or false, do IUDs need to be removed if a woman experiences pelvic inflammatory disease? So we'd like you to please select an answer here. Okay, so the poll indicates that most people, 64%, believe that the IUD does not have to be removed, and 24% felt that it does. 12% really weren't sure. And so moving on to the discussion about, you know, and this is one of the myths as well, is that the IUD does not necessarily need to be removed. So we're going to talk about some myths, but you know, in terms of how you manage a woman who has pelvic inflammatory disease with an intrauterine device in place. If the woman is mildly symptomatic, antibiotics can be started, and the woman has to be re-evaluated just as any other woman with pelvic inflammatory disease in 48 to 72 hours. If she seems to have significant resolution of her symptoms, you can keep the IUD in place and continue her antibiotics. The very new 2016 selected practice recommendations for contraceptive use actually discuss strategies for dealing with pelvic inflammatory disease with IUDs in place, and they have left it to the clinician discretion that if there does not seem to be significant resolution in that 48 to 72 hours, you can go ahead and remove the IUD and see if this enhances resolution. If not, I mean, you really have to reconsider your evaluation. So additional myths about IUDs include the fact that some people believe that they are abortifacients. They actually are not. What we found and what we'll talk about in a few minutes is that they really prevent fertilization. Also, there's a myth that they're very large, but many women really have a poor understanding of the size of their anatomical structures, the size of their uterus, the size of the IUD. Now with small sample devices, we can actually put it in their hand and let them see it and feel it and have a better understanding of how big it is. Also, there's a concern that they can cause ectopic pregnancies, and they do not. So the issue with that is they actually decrease ectopic pregnancies because they decrease overall pregnancies. However, in levonorgestrel containing methods of contraception, there can be, if a pregnancy does occur, in the rare condition that a pregnancy may occur, you have to rule out ectopic. There's an increased likelihood that that pregnancy might be ectopic. IUDs do not cause pelvic inflammatory disease or pelvic infections. Chlamydia and gonorrhea cause pelvic infections. And again, we need to separate a contraceptive method and counseling about a contraceptive method from counseling about sexually transmissible infections. And all women, you know, should have a discussion about, you know, how to prevent those types of infections. The other issue is the need for the IUD to be removed for inflammatory changes on a Pap test. So what we're talking about here is ALO or actinomyces-like organisms. These are normal flora in the female genital tract, and sometimes they're found on a Pap smear. But the current recommendations state that, if a woman has no symptoms, the woman does not need to be treated and the IUD does not need to be removed. However, if the woman is symptomatic with pelvic pain and nausea and fever, then begin antibiotic treatment, and when the antibiotic treatment is underway, then her IUD can be removed. There's also a question about fetal anomalies if a pregnancy occurs, and this is not true. We've all heard the urban legend of the baby being born with the IUD in its hand, and this certainly can happen. It's an extra, amniotic device. So this certainly doesn't happen, and there are no known anomalies. What can happen, though, if the IUD is left in place with a pregnancy, is it can increase the risk for premature delivery or miscarriage, as well as, a septic abortion. So IUD truths include that they can be used by women who have had an ectopic pregnancy. That is not a contraindication. These devices can be inserted in the same day. If a woman comes to your center and wants an IUD that same day, you don't have to wait for results from testing for that IUD to be inserted. Again, I'm going to refer you back to the CDC's selected practice recommendations for contraception that was just published a few months ago for looking at actually procedures related to this. They recommend that the woman have a cervical evaluation and a bimanual exam, but if she has no overt indication of a cervicitis, you can do, if she's at increased risk for a sexually transmissible infection or cervicitis, you can do gonorrhea and chlamydia screening that day and go ahead and insert her device. And again, if she's asymptomatic and if she comes back positive for any of the infections, you can just go ahead and treat her. They can also be started immediately postpartum or post-abortion, and there is an increased emphasis on doing this at this time. They also can be used very successfully by nulliparous women, and in a number of countries throughout the world, it's probably the leading method of contraception in young nulliparous women. They also, again, as we've seen previously, have very high continuation rates, up to 87% at 1 year. So this is a slide that discusses the types of contraception and their mechanism of action. The first contraceptive device that we're looking at is the copper T IUD. This prevents fertilization by reducing sperm motility and viability. It also appears to be toxic to oocytes. So perhaps there's a secondary mechanism of action in terms of inhibiting implantation, but that certainly is not a primary mechanism. The other methods that we have here are the two levonorgestrel containing intrauterine systems. The one contains 52 milligrams of levonorgestrel and the other at 13.5. And they work by inhibiting fertilization and causing cervical mucus to thicken, which then does not allow the sperm to move through the cervical barrier. So again, perhaps there's a secondary mechanism of action in terms of inhibiting implantation, but that is not their primary mechanism. And again, they do not inhibit ovulation. If they may inhibit ovulation on an occasion, but that is not their mechanism of action. So this is the copper IUD. It goes under the brand name of Paragard, and it works with the release of copper ions. It's approved for 10 years of use, but we know that it is effective for up to 12 years. It is also something to remember as the most effective method of emergency contraception for women if it's used within 5 days after unprotected intercourse. And these are the two types of levonorgestrel systems that are here. The 52, the levonorgestrel 52 includes Mirena and Liletta, and they release about 20 micrograms per day of levonorgestrel. The Mirena is approved for 5 years. The Liletta is approved at this point for 3 years, but that's because that's all the data that we have at this point. And there is some anticipation that it will probably be approved for 5 years. There's also the Skyla. The Skyla is physically a little bit smaller and narrower than the Mirena, again releasing only about 14 micrograms, and it's approved for about 3 years. So the difference in size between the Skyla and the Mirena is the Mirena's horizontal length is 32 millimeters and its vertical length is 32 millimeters. So that's the size of this. When we get to the Skyla, it's 28 millimeters in horizontal length and vertical length 30 millimeters. So it's a little bit smaller, and it has mostly been used by nulliparous women. So counseling for individual preferences is extremely important. So we need to know a little bit about who this woman is and how her menstrual periods are in order for us to, to provide her with the best method of intrauterine contraception. So the copper IUD is ideal for someone who really doesn't want any hormones whatsoever, who wants regular periods, and also someone who has normal or light menses, menstrual flows. One thing that we do know about the copper IUD is there's a slight increase in menstrual flow that can happen with the use of the copper IUD. The levonorgestrel containing IUD, such as the levonorgestrel 52, has actually been shown to decrease menstrual blood loss by about 80%. So it has an indication for heavy menstrual bleeding in itself. So again, women who have very heavy menstrual bleeding or have significant dysmenorrhea may have greatly improved menses. And it's a quality of life issue here. And again, it's also an excellent method of birth control for these women with these kind of menstrual problems. The levonorgestrel 13.5 system, again, would be someone who wants an even lower dose of levonorgestrel, or who maybe is planning for only a 3-year hiatus between children. So there are very few contraindications to intrauterine contraceptive use. And of course, you would not want to put one in if you knew or suspected someone was pregnant. Any indication of puerperal sepsis or post-septic abortion or unexpected vaginal bleeding, those are all considered contraindications. The other things have to do with structural anomalies that would not allow correct placement of the IUD, such as fibroids or a uterine septum. Any type of uterine or breast cancers, mostly for the hormonal IUDs, and any active purulent cervicitis. That person should be treated before the IUD is inserted. So next we're going to talk about the single rod implant. The current single rod implant that's available is under the name Nexplanon. Implanon was available before. The difference between Implanon and Nexplanon is Nexplanon has a different inserter that prevents deeper penetration of the device. It really keeps it subdermal. And it also is coated with barium in order to allow localization with an X-ray or a CT scanner. So it releases about 30 to 40 micrograms per day of etonogestrel, and it's approved for 3 years. It's placed in the upper arm. The pharmaceutical company mandates training through them for insertion. So implant myths, it certainly has its degree of myths as well. So this does work by preventing ovulation. But again, as any progestin-only method, it also increases the viscosity of cervical mucus that then decreases sperm motility and viability. It does not cause ectopic pregnancies. But if on a rare chance that a pregnancy does occur, you would have to rule out ectopic because there may be an increased likelihood that that pregnancy may be ectopic. There is not an increased likelihood of infertility after use. Actually, return to fertility is relatively quick, and women can ovulate after removal of the device in as early as 3 weeks. So the average period of time for return to fertility is 3 weeks to 3 months for women. They are not large and they do not move around through the body, and they don't really require surgery for insertion and removal. The insertion process is actually very quick. We're going to look at that in a minute. The actual implant itself is about the size of a matchstick. So it's very small and it's very flexible, as you can see in the picture, with slight bending. And there are patient teaching devices out there where you can actually show a patient what this looks like. And there are little kind of faux arms with the device under the skin so the woman can kind of judge what it feels like. We happen to have a number of women who work in our center who have the device in their arms, who are very happy to let prospective users actually look at their arm and feel the device under their skin. And we've found that to be very helpful for women who are considering this method. So one thing to think about here is, again, with counseling, we really have to talk about advantages and disadvantages. And we need to be very honest about these as the woman is moving into making a decision about having an implant put in. Again, they're highly effective. They're in the top tier of contraceptive efficacy. They are long-term, so it's 3 years without having to do anything. Rapid reversibility we spoke of, and they need to understand also that even though it may take some women up to 3 months to become pregnant after removal of the device, ovulation can happen as early as 3 weeks, and if they're not planning a pregnancy that quickly, they need to use another method of birth control. The procedures to insert and remove are relatively rapid. Insertion is, a matter of like a minute, and removal is about an average of about 3.5 minutes. Women can use this when they're breastfeeding, and there are lots of non-contraceptive benefits to it that include improved menstrual cramps. There was one study, it was a 2-year single-arm study of 187 women who actually demonstrated a significant decrease in dysmenorrhea from using the implant. And again, we're talking about quality of life issues for women who have severe dysmenorrhea. So some of the disadvantages, are more of an annoyance, but they can create problems with women deciding not to use a highly effective method of birth control. And the bleeding irregularities are probably those who are listed as the most common. So certainly in the first year, they are found to be a little bit more common. Approximately 33.6% of women had infrequent bleeding. 22.2% of women had amenorrhea, and about 17.7% of women actually complained of prolonged bleeding, although it's usually light, and frequent bleeding at 6.7%. So the bleeding irregularities, if we warn women that this can happen and have them contact us, there are ways, again, that we can address this. I'll refer you back again to the U.S. the U.S. selected practice recommendations for contraceptive use, and there they have a number of strategies, including the use of nonsteroidal anti-inflammatories as like a first line to deal with bleeding irregularities. In there, you know, probably the most commonly used was celecoxib or Celebrex for, again, treating the bleeding irregularities if it's more bleeding than they are used to. The fact that it is unpredictable is a relative given, and they need to be counseled about this beforehand. This does not bother most women as long as they know that it is not something that will harm them. In terms of weight gain, approximately 2% of women complained of weight gain, but we know in the study that there was not a significant, it wasn't statistically significant in terms of the amount of weight gain that people experienced, and nor did many women discontinue the product because of that. Some women did complain of some emotional lability as well as headaches. Some women had an increase in acne, and 1% complained of depression. So again, in discussing, you know, potential side effects, I think it's important to differentiate between what women may experience in the beginning of use, because typically these kinds of things may resolve on time, and what kinds of things they can expect on an ongoing basis for the 3 years. So initially, again, they're going to have some slight bruising or discomfort at the insertion site, and they're more likely to have that spotting or more frequent irregular bleeding initially in that first year. They also may experience some hormonal types of side effects, and depending on how well they can tolerate these, you know, you may be able to provide some additional type of supportive practice, such as nonsteroidal anti-inflammatories, to help them get through this. Ongoing, though, they need to understand that their periods will be light, and certainly some percent may have actual amenorrhea. We know that they remain unpredictable. But they do not tend to be more often or heavy. Anything that is heavy or more frequent should be reported. And there are very few contraindications to implant use. And actually here I'm going to refer you to the new medical eligibility criteria for contraceptive use, which again came out the partner to the selective practice recommendations in 2016. So the existing contraindications to implant use are pregnancy, unexplained vaginal bleeding, occurrent breast cancer, especially if you're talking about, you know, something that has hormonal receptor site positivity, severe cirrhosis, because again, you know, the liver does have to metabolize the hormones here, and a malignant tumor, liver tumor. So the implant insertion and removal must be done by a trained provider. Again, insertion time is about half a minute to a minute, and it can be done at any time that the clinician is reasonably sure that the person is not pregnant. It's recommended that a backup method is used for a week, because again, ovulation suppression is the primary mechanism of action. You know, so if this method is not being used within the first 5 days of menses, tell them to use a backup method for 7 days. And again, that's in selective practice recommendations. Removal time on an average is about 3.5 minutes. Things to remember about removal is to make sure that the local anesthetic is injected underneath the device, because again, you can obscure the distal end of the device where you want to remove it and make it a little bit hard to identified by touch. So this is the implant location. Again, the guiding mark is that medial epicondyle, and it's about 8 to 10 centimeters in, and it is done just subdermally, you want to be careful to avoid the sulcus between the biceps and the triceps because, you know, deep in that sulcus is actually a network of vessels and nerves that you want to avoid. But again, it's very superficially inserted, and the new applicator makes it very easy. So what we're going to talk about now is contraceptive counseling and follow-up. Here we have Anna, who's an 18-year-old G0, P0 who wants a low maintenance method. And so think about, you know, what that would mean to somebody that you were seeing in your particular clinic. She's a high school senior, so, you know, you need to know what her plans are. She has been sexually active with a boyfriend for 3 months, and again, you need questions about what kind of sexual activity they're having. They've been using condoms for contraception, and she does not want to use a hormonal method of contraception. So again, what does she mean by a hormonal method of contraception? So here's our second polling question. Which method would you recommend for Anna? So we'll give you a little bit more time, about 30 seconds or so till we close the poll. But I'd like to see what your thoughts are here. Okay, so most of you are really talking about copper IUDs, low hormonal LARC methods. Okay. Sorry, bring this back up. So your thoughts on this? Again, she doesn't want a hormone, but what does hormonal really mean to her? And sometimes that just means combined hormonal contraceptives. She might have had an experience with them in the past, or might have had friends who have had experience with them in the past. Again, low hormonal options, when we're talking about the levonorgestrel containing intrauterine systems, they are mostly local in activity, and there's very, very low systemic hormones, and there's no estrogen there, so there's none of the typical estrogen-related side effects. Again, the IUD has no hormones whatsoever. So, you know, that certainly is an option, but some of the other things that you need to think about and have a conversation with her about is, what are her menstrual cycles like? Does she experience menstrual cramps? Does she have a heavy flow? How long would she like to use the method? Again, the implant does have more systemic hormones that are available in terms of the etonogestrel, and again, it does cause ovulation suppression. So, you know, her menses, would it bother her if her periods are irregular? On levonorgestrel, would it bother her if her periods disappeared? Those are all part of the conversation that she should have, but one of the things that you need to be aware of is the new recommendation by the American Academy of Pediatrics, really recommending that adolescents should be counseled first on the most effective methods available, and that includes the LARC methods. So really prioritize them. But, you know, most important is also, you know, one question, you know, what are her life plans? When is she thinking about, or is she thinking about a pregnancy in the next 1 year, 3 years, 5 years, 10 years? So recently, there's been a lot of emphasis on shared decision. I know that when recommendations are made in an authoritarian kind of way from a healthcare provider, they're least likely to have buy-in from a patient. And again, it's a long way from the exam room to the bedroom. Something that might seem like a good method in the exam room may not turn out upon use, you know, being the ideal thing that a patient felt. So, you know, they really need a very thorough discussion of risks, benefits, side effects, and an open door. You know, you really need to realize the fact that they can change their mind at any point, that there are other methods of contraception available. Establishing trust is really important, and that's an ongoing kind of thing. But certainly asking them about their preferences. What do they have in mind, and what do they want in a method? What's important to them? And also, what are other options? We need to be very careful and cognizant of our own internal biases and to try to keep them out of the discussion with a patient. It really does not serve that patient well at all to introduce our own personal biases, but then we need to be aware of them. We also have to make sure that they have access to method placement and removal. And give them enough time, not, 5 minutes. Giving them enough time for thoughtful questions. And a mechanism called teach back. So that would be asking them questions and having them repeat information back to you. Remember that in this session that you have, this educational session that you have, they're probably only going to remember about 10 things, or maybe 10% of the information that you give them. So teaching back is a good way to have them produce and repeat information that you feel are the most appropriate and most important aspects of using that method of contraception. But again, the fact that that door is always open and the phone is always there for additional conversations. So again, counseling topics, efficacy, needs to happen. Pull the chart out with the 3 tiers of efficacy in terms of contraceptive methods. Mechanism of action. They need to know how they work. You need to talk about myths. What have you heard? What do you think? What might be a problem for you? Counseling, again, on menstrual flow. And so that might be periods getting heavier or periods getting lighter. We live in an age where changes in menstruation, anything other than our normal menstrual flow might be worrisome to us. So making sure that somebody knows ahead of time that very, very light spotting, just using a panty liner, is totally normal with the higher content levels of levonorgestrel in our uterine systems. Return to fertility is important, so that they understand that their fertility is not going to be impaired if they use a long-term method of contraception, and also so that they can protect themselves adequately after removal of the method, unless they intend to get pregnant immediately. Side effects, complications, what the procedure is like, insertion and removal. And again, I'm going to add in here if they are a known fainter with things like blood draws or other procedures, you can counsel them ahead of time regarding vasovagal prevention in terms of a procedure that's called applied tension technique, where you can actually have them use this technique even in the middle of an IUD insertion and shut down a vasovagal response. It's been proven to be quite effective. But training somebody in that prior to the insertion time would be very helpful. And again, what to expect on follow-up, as well as condoms and new partners. These are really important issues. So the one key question, and this is what we had mentioned before, is that do you want to become pregnant in the next 1 year, 3 years, 5 years? And this is an important question that they need time to consider. Follow-ups. Again, the selective practice recommendations discuss lots of variability and follow-up. You can leave it up to the patient in terms of there are some practices that automatically bring back individuals who have had intrauterine contraceptive devices inserted. They bring them back after the first menses. There are some data that indicate that if you're going to develop a uterine infection, that it happens within the first 20 days after the device was inserted. Also, if there's a concern as to whether or not somebody's going to expel a device, some practices bring somebody back after their first menstrual period and also check in with satisfaction and are they having any abnormal bleeding or other issues. Other people can follow up on the phone. So there are lots of different strategies for follow-up that you can consider. And again, the selective practice recommendations will help you sort through those. These are some resources for patients. ARHP has a fabulous methods match site that actually lets the patient go in and look at key attributes of contraceptive methods that are important to them. And then it'll show them what methods might match with those attributes. There's also Bedsider organization, and Bedsider organization actually has some great resources that you can use in your clinics as well. And this site is funded by the National Campaign to Prevent Teen and Unplanned Pregnancy. So you'll find a lot of the language and the teaching materials are very teen friendly. These are resources for clinicians, and again, these are the MMWR publications, the MEC guidelines, as well as the SPR recommendations, and you can see right in the center there is an app that you can put on your phone that has both the MEC guidelines and the SPR guidelines. That will have a digital platform that you can just pull them up on your smartphone. And then there's also the MMWR providing quality family planning services that will really help place all of this within the context of a greater life plan. So at this point, we'll take questions.
Great. Thank you, Wendy, for that excellent presentation. This is Jessica again, and I will start reading questions that have been entered into the question box. So our first question is from John, and he asks why it's suggested that a backup method be used with the LNG IUS during the first week. Since the rate of pregnancy over 5 years is less than 8 per 1,000 women, he would like some clarification on the purpose of the backup method.
Well, I think that that's a good question. And, again, I would refer you to the MEC guidelines and the SPR recommendations there. And it's probably because, there is still it's possible that there are remaining sperm, especially if the sexual intercourse has happened recently that was unprotected, that there might be sperm within the genital tract somewhere that could create an issue with possible pregnancy. But also endometrial thickness. It takes a little while for the thinning of the endometrium from the progestin to occur.
Great, thank you. Our next question is from Pamela, who would like a little more explanation on the applied tension technique to help with vasovagal reaction.
Great. So the applied tension technique, and actually I would recommend that you look this up. This was developed in the mid-1980s by a Scandinavian physician, I believe, that was looking at people who vasovagal with blood draws. And he was looking at a mechanism to prevent vasovagal. And this is really, so you can look it up, and it gives some great visuals for using this. So this technique is having the person clench the muscles in the arms and legs and abdomen as tight as possible. And we usually do a count of about 10 to 15. Again, when you're thinking about what happens during a vasovagal episode, you have dilatation in the limbs, vasodilatation, and pooling of the blood there. So you really want to push that blood right back into the core. So you have them apply this tension in the muscles in the arms and legs for about 10 to 15 seconds, and then release it again for maybe about 30 seconds or so, and then apply it again. We have them repeat doing this maybe about 4 or 5 times.
Perfect. Thank you. Our last question is from Kimberly, and she asks, could you please discuss more about LARCs and breastfeeding? One concern I've heard from women is that LARCs cause a lowered milk supply, especially if inserted in the first month postpartum when milk supply is rising.
I'm sorry, could you repeat that again, please?
Oh, sure. Kimberly would like a little more discussion on LARCs and breastfeeding. She's heard from women that concerns that LARCs cause lowered milk supply.
Oh, lower milk supply. Okay.
Yeah.
Okay.
Especially if inserted in the first month.
Again, I am going to actually refer you for complete details to the U.S. Selected Practice Recommendations for Contraception. So they really talk in detail about progestins and breast milk development and things like that. So, I'm going to say that, recommend that you go back and look at the details in there. And generally feel, they're considered safe and no problem for the fetus at all. Let me see if I can find their comments. I'm just going to, suggest that you go back and again, take a look at you're talking about the progestin-only methods. Are you talking about the implant or the IUD?
It doesn't specify.
Okay.
But the concern is that it would lower the milk supply in the first month when milk supply is still rising.
Well, there does not seem to be a concern about that with the levonorgestrel IUD in the new selected practice recommendations. But I would again say that that is the source for some of these detailed answers that you need. So everyone should have a copy of that and refer to that specifically when developing their practice guidelines.
Great, thank you. So unfortunately, we won't be able to answer everyone's questions right now in order to wrap up the webinar on time, but if your question wasn't answered, please just submit it to education@arhp.org, and we will follow up with you. Dr. Grube, would you like to go over the key take-home points before I do a little bit of a wrap-up on CME credit?
Sure. So again, the main things are that even as you look at the new CDC MEC guidelines, they now have switched the direction in terms of how they discuss contraceptive to putting LARCs up front. So they have the highest efficacy and continuation rates. Again, of all the reversible methods, we consider them like reversible sterilization. So this should now be emphasized if we're going to address this almost 50%, we're at 45% unintended pregnancies, and again, half of those are women who are using a method of birth control. So if we're going to impact that number, we really need to look at good methods. Most women really are candidates. Very few women are not. We need to be very careful about counseling women in terms of giving them all the information they need to make the best decision for themselves, recognizing our own biases and keeping them out of that discussion, and also providing them with evidence-based resources on their choices, giving them all of the choices. That's what true informed consent is.
Great. Thank you so much again, Dr. Grube, for this excellent presentation. Before we end today's webinar, I'd like to share a few important reminders. Please be sure to join us for the second webinar in this series on September 14th. Registration is now available, as Dr. Grew mentioned in the earlier slide. As an additional reminder, you will receive an email from Caitlin Borsowitz in about an hour containing a link to the post-test survey. Your CME or Nursing CE certificate will be generated at the end of that survey. Please be sure to print this certificate before closing the internet browser. If you have questions, just email us at education@arhp.org. Thank you again for joining us today. We hope you will be taking part in the live and on-demand sessions hosted by ARHP. Thank you.